Okay, well, we'll go ahead and get started. There are still some people out there. This is going to be a fabulous session. I hope you enjoyed the first part of the morning as much as I did. And this now is going to be something that I think you really will enjoy. This is a session on atrial fibrillation. We haven't had one of these at this meeting for 4 or 5 years, I think. And this is a subject that I think is grossly overlooked by surgeons, and an area where we definitely need to have a raised level of awareness and education. Now, Ralph Damiano, whose name is up there, was to be one of the speakers, but unfortunately he could not make it because of travel issues, and he was stuck in Atlanta last night and has called to apologize. Niv Ad and Steve Hoff will be delivering the talks, and Niv will moderate the session. Niv needs no introduction. He is, I think, the preeminent surgeon in the world today in this area of atrial fibrillation, certainly one of 3 or 4, less than a handful. Steve Hoff has also made a name for himself in this area, and I'm very, very pleased to have them both over here and very grateful to them. Niv will be giving Ralph's talk, and then we'll take it from there. So, Niv.
Good morning, and thank you, Mahesh. When Mahesh asked me to try to put together an AF session in his meeting, I was very pleased, and one of the plans was to bring Ralph to talk about an area it's really important, which is ablation technologies for atrial fibrillation, and how do we decide what to use and why. And recently, I'm very obsessed with decision-making process, and actually going to come out with some, I believe, some interesting aspects of it. But I want to read you something from what's considered to be a very smart man, Daniel Kahneman, who is actually known to be the Nobel Prize winner for economy, but is also a well-known psychologist. And he said something that I will read, which would say, we think, each of us, that we are much more rational than we are. And we think that we make our decisions because we have good reasons to make them, even when it's the other way around. We believe in the reasons because we've already made a decision. And I think this fits very, very well to what I personally hear for many, many, many years around the field of atrial fibrillation. And I'm often being perceived as too critical about innovations and anything other than the full MACE procedure. But, you know, I think that as a young person, when you start to perform operation by yourself and decide about your career, you have to make a few important decisions. And I always go back to a sentence I read in the Sabitstone book, textbook, when Floyd Loop wrote the chapter on redo cabbage operation. And he starts with, you need more than a good reason to reoperate on a patient with a patent lemma to the LAD. So with that being said, you know, everything I know and do with AFib surgery is based on what I was learned from Jimmy Cox. And Jimmy Cox told me that you actually need more than a good reason to move away from the cut and sew MACE procedure to the cryo, which was done while I was his fellow, and move on. But we have to understand also the fact that the field may not be moved forward as much as we want it to move, because it's being perceived maybe as too confused, too aggressive, underperformed, all of the above, etc., etc. So while we push progress, we have to understand the principles of what works and what not. And we think it's very important to start with technologies, because not everything we hold in our hands work, and not necessarily what we use in our work that may work in some hands and not in others is utilized the right way. And the best example for it is actually a failed trial for IDE by Medtronic, the CURE-AF. And what's interesting in the study is that if you look at the results from the centers, the results with the same technology, with the same lesion set, were 0 to 100% success rate. So what it tells us that the devil is in the details, especially when it comes to AFib. The other point that I want to make, which is really important before I start the talk, AFib, unlike coronary bypass, unlike valvular heart disease, unlike anything else, even at the end of the interventional cardiologist or the EP, it is still an art, meaning there are variation between an operator to an operator. You can put a stent in a coronary and it doesn't matter who puts the stent. And that's what we are up against, technique versus technology. And it's 100% of the time we're going to lose when it comes to technique versus technology. But when it comes to AFib, the technique is still important and the technology is somewhat a tool to perfect the technique. This is the way I look at it. And this is why we see those variations between operators, even in the EP world. So let's start with Ralph's talk. I hope I got it only this morning, so I hope I'll do a good job as that he would approve, because he's really the world expert when it comes to technologies, and he tested all of them in his lab. And Matt, Matt Shear is here, is the research fellow. Raise your hand. He's a research fellow in Ralph's lab, and if you have anything to add, just please raise your hand and okay, and help me out. So basically, what's the most important goal of a surgical ablation device? First, you have to have consistently transmural and continuous lesions. So you have to be consistent 100% of the time. And the lab in St. Louis showed, like other EPs showed before, that all you need is a very small gap to reconduct. Very small gap, 1 millimeter, and there are works actually in the EP world that even less than 1 millimeter is enough to conduct. So the original surgical ablation device is basically the cut and sew maze, or the cut and sew left atrial isolation, or the cut and sew left atrial transection, etc., etc. So you cut and sew, so you have no question, you divided all the fibers. But there are questions whether reconduction across those lines can occur, and there are some anecdotal reports that show this. But even with the cut and sew maze procedure, there were cryo lesions, basically to complete the AV groove lesions, and we may talk about it later. So this is how it looks. A weave of lesions across the left and the right atrium from the back. There's IVC, SVC, 4 pulmonary veins. So the basis of it is pulmonary vein isolation as a box, going towards the base of the left atrial appendage, and appendectomy in both of them, and then the right atrial lesion. And the excess represent cryo lesion, actually. Now, what you see here is actually a lesion that I think I'm the only one still doing it, and everybody that was in my operating room and saw it and learned it from me is doing it, is the septal lesion. Because if you look at the theoretical aspects of the maze procedure for failure, this is one of the areas that you might have a failure, and we may talk about it more. But in the original maze procedure, this lesion was not, or this cut was not made on any basis of findings, but more to enhance exposure. And these are the results as published back in 2003. Which kind of very impressive, 96% in sinus rhythm, 80% if you take only off medication, and AF 4%. But this study is criticized because we're not using modern tools for tracing AF, such as halters and event monitors. But I always say this study is very important because when Carpentier came with his results on mitral valve repair, nobody said, oh, you didn't repair the valve because you can't show echo on all of them in long term. So I think it's an evolution in the way we look and the way we define success in failure, and we have to keep everything in perspective. And we'll talk about it maybe in the second half of the talk, that we will, I hope will generate some questions afterwards. So only several hundreds cut and sew maze procedure, but technology happened and helped us to perform it quicker, more efficiently, and basically thousands of patients since then were ablated successfully or not. So the advances in the last decade can be defined into ablation technology to replace the surgical cut and sew maze procedure, and by so doing we can have less invasive surgical approaches. So there are multiple devices that were introduced over the years and multiple devices the left. So you have the bipolar clamps here. These are the old Atria, the cardio ablate system, cryo ablation with, this is a Medtronic today. And then in the middle you see the laser, microwave, and the HIFU device. And those are all out. So what's left to us today is a unipolar RF, which is the original Cobra here, but I'm talking about the family of it, cryoablation and bipolar ablation that we think worth the discussion. So how you test efficacy of the devices? You basically go and over certain parameters, and we'll go over some of those graphs. But the FDA basically defined most of those devices in the US as appropriate for soft tissue ablation, with the exception of the cryo devices, both by Medtronic and Atria, that are defined for indication for any cardiac arrhythmia. And then basically, because of soft tissue ablation and a very soft definition, we got this kind of jungle of devices that we don't know what exactly they do, but they can ablate tissue, but to what end? And in the lab in St. Louis, they have the long-standing grant, and they basically go over all devices available and try to validate them. So we know that the challenge with ablation devices is the variability between patients and the variability within the cavity that you are ablating, and when it comes to the amount of epicardial fat and tissue thickness. And also, when you do beating heart surgery, the heat sink effect is important as it carries or mitigate the influence of the ablation warm or cold when it comes epicardially. So variability over atrial wall thickness can go between less than 1 millimeter in the thinner areas to more than 2 centimeters in the thicker area. And as you can see here, most of you are familiar with all of it, but the lateral ridge, for instance, is very thick, and the area of the coronary sinus and the fold are very thick as well. And as you can see here with illumination, some areas are very thin and some areas are very thick. But some areas are also trabeculated and some areas are not so trabeculated, and that goes make it even more importantly when it comes to the right atrium. And the right atrium is the most abused one when it comes to ablation, especially epicardial ablation and other aspects of ablation. And I'll talk about it in terms of what data that we really have is pacemakers, but also the potential harm while ablating incomplete lesions on the right atrium, especially because of the trabeculation and the three-dimensional aspects of the way it looks, of creating lesions that are incomplete and basically serve as a nidus for their next arrhythmia. And it's interesting, when you follow, even in my short career, so to speak, in atrial fibrillation, when you follow the mode of failure of today as opposed to what it was even 10 years ago. 10 years ago, patients failed with atrial flutter, left or right, if you didn't do the mitral isthmus line appropriately. And actually, in the original MACE procedure, they used to leave clips where they did this mitral valve isthmus line, metal clips, so when and if the patient will have left atrial flutter, or what they call today mitral flutter, which is atypical flutter, the cardiologist will know exactly where it is so they can complete the lesion. So that's hybrid procedure, per se, happened in 1987. By the way, this September 1987, almost 30 years ago, is the first MACE procedure. I think that it's important to notice all this and understand that, because the arrhythmias we see today, because a lot of what the patient had incomplete catheter ablations, are more focal arrhythmias, multiple different type of arrhythmias, etc., etc. So even that shifted because of incomplete lesions. So that's really, really important. And obviously, we are talking about the Bachmann bundle, which is in the top of the left atrium, going from right to left, which is kind of a band that conducts between the right and the left atrium very, very well. So there are two important aspects. One is try to ablate the Bachmann bundle epicardially. It makes it almost impossible because of its thickness. But secondly, if you are aware of the history of the surgical ablation of AF and the COX-1, the COX-1 was very, 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 very effective, but it cut through the Bachmann bundle and created a situation where the right atrium was beating ahead of the entire heart. So the delay between the right atrium and the left atrium was exactly like the delay between the right atrium and the ventricles, which was about 180 milliseconds. And therefore, this was one of the reasons the procedure was discontinued. So some of the ablations that we are experiencing today, like the 5-box or the Dallas lesion set and so on and so forth, are going across the Bachmann bundle, which I think it's conceptually wrong. And thankfully, because it's being done epicardially, it's unsuccessful, so we don't see this problem. But if it was successful, then it's a problem. So let's see what's the ideal technology. So considering there is a wide range of wall thickness of the normal and pathological atria, it is intuitively obvious that any device delivering a set amount of energy for a set amount of time is unlikely to be consistently make consistently transmural lesion. So you have to understand that, and every time you ablate a patient, this is a challenge we have. And right now, we are working with the companies on the next generation device to improve our ability to monitor the lesion as it's being made and not as it being delivered, which is a different concept. So Epicardial Fat, I don't think we have to show it. All of us here are familiar with it, and this is a challenge. It's very, very easy to explain that the more pericardial fat you have, the harder it is to get to the actual atrial tissue and ablate. And I will talk a little bit about atrial myopathy and some pathways that we recognize as in basic science that are upregulated within the mitochondria, and it's are actually pretty much involved with fat metabolism as well. So I think it's not coincidental that you see more fatty hearts in patients with atrial fibrillation than not. The heat sink effect is very, very important, and let's just explain what it is. If you come to ablate from the epicardium and you have to go through the fat and then get through the muscle, and imagine you have this 5 to 7 liters of blood flow basically in a set temperature. So if it's a cold temperature or a warm temperature, RF or cryo, you are basically washing everything very, very quickly. disallowing at least, or the least you're disallowing, let's assume that you can penetrate the others, the subendocardial region to be well ablated, and even more than that. So therefore, different devices were utilized, but not necessarily utilized the right way. The microwave, for instance, was removed from the market, and I can tell you, just before it was removed from the market, I actually started to work with a company on a pulse therapy with microwave that actually showed to be very, very efficacious. But if you were looking at microwave in the context of non-beating heart conditions, meaning putting the patient on bypass, maybe we would have an excellent device. And let's see how we can tell it. So in the lab, they basically looked at the different aspects of cardiac output per liter per minute and the transmurality of the lesion. And as you can see here, this is a longer lesion, this is a shorter lesion. There is no pulse therapy here, but the higher the flow, meaning the heat sink effect, the lower the transmurality. But when you get to a very low flow and a longer period of time, you get transmural lesion with a microwave technology that is no longer in the market. So I think this brings the point that it's very, very, it can be very, very effective, but depends on how we use the technology and whether we should reconsider it or not. It's a different question. So how do we overcome those shortcomings? Well, all unipolar devices we have tested to be very poor at creating transmural lesions. All of them. I mean, it doesn't matter if it's cryo, on beating heart epicardially, or it's any of the RF technologies. It doesn't work well. You can do the unipolar irrigated devices, suction devices, you name it. I mean, and it's a very relatively very simple way to test it. If you have the line here that represent a transmural lesion, and I'll get to the definition in a second, you can see that basically many of those dots are not where they were supposed to be, and almost unrelated to the amount of time that the ablation took place. So if you have something that's only 80% of the time transmural, it's a problem. Now there is another challenge here, because when you ablate with an epicardial device along a line, okay, there is a question whether each dot or each area that you section the heart is transmural, and the integrity of the entire line. And I think you'll see in the other works that basically these are two very, very important. You can have a lot of sections transmural, but but the line is not transmural, because not all the sections are transmural. So if you say 92% transmural, it's the sections, but it can be 0% transmural in a line, which is not always happens, but theoretically can happen. So if you have a line that it's not transmural, it doesn't matter the 96% of the dots or the sections when you did it are transmural. Transmurality is defined as we said, by pathology only. So epicardial bipolar devices, the cool is the most important one, and going through some scrutiny nowadays as part of the issues with the deep trial that we may be able to discuss later. And as you can see, again, 72 cross sections, 77% of them were transmural, with average depth of about 3.7 millimeters. So would you use a device like this as a standalone therapy? I don't think so. Would you use a device like this as a hybrid therapy? That's remained to be seen, because the basic principle in business is that if you have a failed startup, you can't resuscitate it with another failed startup. And we know that if this is failing, how can you resuscitate it with a failed technology, which is endocardial ablation? But I may be wrong, because there are some interesting work, and Steve will talk about it after I'll get you all exhausted, that you can actually get some maybe good results if you work together. So, so by mapping, none of the 12 linear lesions demonstrated conduction block at 30 days. So 77% transmural, none of the lines has conduction block. So that's another important point. When we introduce a technology to ablate the atrium, the acute results may be completely different than the chronic results. And this goes back to something that came from Steve's place when he was in Nashville, that actually we're able to show, and I'm sure he will show you, that there is a difference if you do a single-stage hybrid or a delayed-stage hybrid. And I think part of it is because of that acute effect versus chronic effect. You can do an experiment next time you are with an AF patient. You can cardiovert the patient, and I can tell you, I bet you that 5 out of 10 times, just after cardioversion, you wouldn't be able to conduct across the pulmonary veins. You can create an exit block because the atrium is stunned. So acute conduction block is important because if you don't achieve it, you know that there is no acute conduction block. But what does it say about the future of the lesion remains to be seen. Single ablation versus 2 ablation or reduction of the flow in the cavity. And I think this is your work, Matt. Maybe come over here real quick and tell us about it.
So this was actually a study that I wrote up that they had done in the lab around 2012. And they were using, they were performing epicardial bipolar radiofrequency ablation on the beating heart, trying to improve it. Obviously, that's not consistent with the way that the full biatrial coxmaze 4 is performed today. But the idea would be that based on Dr. Melby's work that was discussed earlier, that reducing blood flow through the heart or through performing ablation multiple times at the same site, you could improve the rate of transmurality. And so we see that clinically. Many people will fire ablation devices even just around the pulmonary veins multiple times, resulting in a faster impedance drop and more efficacy. And similarly, off-pump maneuvers that can be safe, such as bicaval occlusion, to reduce blood flow, can significantly increase the transmurality of lesions on the right atrium. Yeah. So, and you can see here, on the left atrium, repeated ablations were significantly more effective with a transmurality rate of 71% versus 92%. However, even though without vena caval occlusion, using epicardial bipolar radiofrequency ablation on the beating heart, we had a transmurality rate of only 24%. In short, it didn't work. With vena caval occlusion, significantly reducing intracardiac blood flow and the heat sink effect of the circulating blood, you had a rate of transmurality that was 81%, which is significantly improved, although I would not say it's anywhere near equivalent to what you could do with an on-pump procedure.
So, unipolar, bipolar epicardial, and bipolar cross-sectional, so to speak, or transmural. So we learned that it is important how we ablate and what do we do in order to improve our transmurality. There are currently 2 bipolar radiofrequency ablation devices in the market. Actually, Atria is owning another one after the acquisition of Aztec. their clamp, but it's not being utilized much, if at all, in the US. I'm not so sure what's going on worldwide. And basically, it's based on a very simple aspect of conductivity, of measuring of the tissue conduction. Now, this algorithm has some issues with it, but because it is based on healthy animals for the creation of the model, but more importantly, the variation between tissue to tissue and surgeon to surgeon, or how many times you apply, but as important, how many times you clean the clamp. So if you have some dirt on the clamp or dead tissue on the clamp, you are basically diverting the algorithm and creating a problem. However, if you do it the right way, this is what you should expect most of the time. There are, though, less recent and more recent reports showing that even if it's being done appropriately, the reconnection or the non-transmural lesion rate is fairly high. And even in the end of one of the most experienced surgeons, Mark Lemaire, in those epicardial ablation, he just published a paper from Belgium showing that in 9% of the cases, he had reconnection across the pulmonary veins utilizing this technology. But this is by far the best technology, RF technology we have. And there are multiple papers to show it, that basically dry bipolar RF ablation has very good clinical results. I can tell you that the saline irrigation is as good, although the device itself has some limitations, so as surgeons, we don't like it so much, but it works well. But very important is that you can achieve transmural lesion or conduction blocks, let's say, not transmural lesion, with about 3 applications plus minus, the standard deviation, with about 30 seconds in each side. The device of today is slightly better than what it used to be. Now you have basically 2 electrodes, so it helps with the algorithm, and it also helps with the width of the ablation line, which probably will improve to some extent the transmurality. This is the width of the lesion, so you see the older generation and the newer generation. Technical tips, so fully mobilize the pulmonary veins. Don't bunch tissue. Make sure it's as flat as possible, because you have to understand that if the pulmonary veins are like 2-3 millimeters thickness, when you bunch them, it's 6 millimeters. If you go to the antrum and the atrium there is 3 to 4 millimeters, when you clamp it, it's 7-8 millimeters in thickness. So it's significant. If you can't do it as a 2, do it in isolated pulmonary veins, 1 by 1. It's as good. And this is controlled by an algorithm, so you have to understand char and fat and air can be of a problem. And the modern way of doing it is to clamp, and we'll show it in the lab. Go for the beep, 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 beep that says that the conductivity is low. Leave it closed and step on it again. And if it is less than 10 seconds, it's probably okay. If it's less than 5 seconds until the next beep beep, it's probably better. And this is the new way of doing it in the past, let's say 18 months or so, and we are looking into the results with that. So it's the shortcomings, it's arrested heart in sometimes. It limits you only to the PVI on a beating heart, and you cannot perform a full maze with it. Anybody that says they can perform full maze procedure with bipolar clamp is wrong. You can't cause safely the AV grooves. Actually, you can cause damage. There are some reports on that, and it's very, very hard to get around the mitral valve isthmus. The unipolar bipolar device, it's a very interesting concept. You suck tissue, and then you ablate bipolarly, epicardially. You get bipolar energy, thin tissue, less than 7 millimeters, and you complete with an algorithm for unipolar. I'm intimately involved with this device in the past. I was the PI for the FDA study that stopped with the acquisition of Aztec by Atria. But the shortcoming of this device is that you can have the entire 7 millimeter or whatever of fat filling your bipolar application and basically negate the entire effect. And as you can see here, this device is 94 of all lesion. As I said, if you just look at the sections, however, only 68% of the lines were transmural. And I just came from Europe a few days ago. We were in a meeting, a big meeting in Europe that one of the leading centers on the fusion device, the EP cardiologist presented the data, and only 17% of the lesions were transmural 6 weeks out, which begs the question, what are we going to do next with this technology? So unidirectional devices, as I said, I don't want to come back to it again and again and again. It's unpredicted, and therefore you have to be very, very careful. We have different cryoprobes. These are the old cryoprobes from Cooper Surgical. This is the Maze probe that was designed by us when we were at Georgetown. We started with a small 5 millimeter probe that we just cut the insulation and created our Maze probes, and then the company came and did it for us. This probe is limited compared to this one, which I'm very familiar with because of the way we designed the head of it. It's flexible, but it's stiff enough. So this is the one that basically is working today. The company has some other devices, but I think that this one is very effective, as you can see here. The nitric oxide based can achieve high rate of transmorality, but again, cryo, you need to be on bypass, and I'll talk a little bit about how to apply cryo when you do it. So endocardial beating ablation, beating heart ablation can result in very high success rate with transmorality. So again, thickness of tissue. Thickness of tissue also is a factor with cryo. And this is a study that's going to be published soon where we compared in vitro the two devices in the market, the Cryo 2 and the Medtronic one. The Medtronic is a device that's based on argon, then go very cold, and the Atria is a little warmer. And as you can see, if we are considering the -30 as a killing zone, then the thicker the tissue is, the less lower temperature you get when it comes to cryo. So, for instance, if you ablate a 6 millimeter tissue to get to the -40, you need almost the entire 2 minutes time before you get -30. I mean, to get to that temperature with the Cryo 2, as opposed to getting to it rather quickly when it comes to the argon base. Why it's important? It's important because we have to modify the duration of the freezing. The problem is that we cannot predict it when we are in the OR, but we need to be aware of it. So what happens if you increase the lesion, the cryo to 3 minutes? I tell you, it may be working well, but it may be not working well. And we are showing it in the paper that actually the algorithm of cooling tissue is different between the two devices. And the longer is not necessarily better when it comes to this device. The rewarming is also very interesting because this is a rewarming of the probe as opposed to leaving the probe for another 20 seconds. And you can see that basically the graphs are at the same rate of rewarming of the tissue, which is another interesting point that I'm looking at it more and more. As important, even more important, when you look throughout the length of the probe, the temperature are not identical in the proximal and the distal part of the probe, okay? This is for the 4 millimeter tissue, and what we had 8 temp probes along the probe, because when you read -60, it's only at one point. It's not in the tissue, which is maybe more important. And as you can see, it changes between the different thicknesses of the tissue, although it's not as important when it comes to the Medtronic one because it's always below the temperature that is the killing temperature. This is a tissue temperature, as I said, but it may be important when it comes to the cryo 2. And as a rule of thumb, I never freeze with a full 10 centimeters with a cryo 2. I always freeze only 6, maybe 7 centimeters because the proximal part, as you can see, can be much warmer. So the igloo effect is important because if the tissue is not dry and you ablate fluid, blood, or whatever it is, you create an insulation. Basically, you are freezing something against the tissue, but it's not the probe against the tissue. But it's also the same apply when you freeze tissue because then you have to push the ice ball forward, and the ice ball maybe isolate you from if the tissue is too thick. So I don't think myself, and this is where I have disagreement with Ralph, that 3 minutes can overcome the thickness of the tissue. I think that actually with cryo you need a pulse therapy, and that's what I do. I freeze. If it's a very thick tissue, I freeze for 1 minute, stop, 1 minute, stop, 1 minute, stop, etc., etc. Or you do 1 or 2 minutes, depends on how it looks when the ice ball is there. It's safe on the valves. Do not rush to rewarm. It's okay, but we have to look at the mechanism. We don't have time of cryo. I don't necessarily agree with that, and you should avoid coronaries as possible. So these are the lesion set of the Cox-Maze procedure, and the only device we have approved right now for that is actually the Atria device, the bipolar one with an indication. But as you see, the lesions are being either cut and sew, whatever technology you use with some cryo, and you can do the entire procedure with a cryo. So the conclusion that atrial wall thickness is variable. We talk about it. Bipolar ablation and cryoablation are the most effective, and you'll see this translate into the guidelines that I will talk about. And you have to be aware of all of that when you are ablating, because I think the real challenge we have now is to move the needle into minimally invasive procedure, and we'll both talk about it in next talks, but maintain the quality, because otherwise we are not going to be successful. Thank you. So now we do